Our special guest today is Dr. Naresh Mansharamani. He is a physician practicing medicine at South Coast Hospital in South Shore and in Cape Cod. He specializes in lung diseases and lung cancer. We are going to talk about that today with him. Naresh, welcome to our studio.
Thank you, Mr. Mishra.
And thank you very much for coming
Thank
here.
you for having me. So let me just start by saying a little bit about lung cancer first.
Okay.
So unfortunately, lung cancer is one of the biggest cancer killers in the United States. If you look at the number of lung cancers that we see, there are 158,000 people that are expected to die in 2015 from lung cancer.
In the U.S.
In the U.S. And worldwide 1 million. And the number of people who die of lung cancer is more than the combined cancer deaths from breast cancer, colon cancer, and pancreatic cancer combined. So the number 2, 3, and 4, if you combine the total deaths in 2015, they're going to be about 120,000. So from lung cancer, we're expecting much higher numbers. The mortality with lung cancer is extremely high. 17.8% people survive at 5 years after diagnosis of lung cancer. And the best treatment for lung cancer is prevention.
Okay.
If you can avoid the lung cancer,
right,
that is where your money is.
So what are the symptoms of lung cancer?
So lung cancer a lot of times can present as an asymptomatic disease. Most lung cancers actually get picked up by that. But what I advise my patients who've been smoking for a long time especially, that if you have a new cough, normally the patients will identify and say, I have a smoker's cough. All right. But if they feel that they have a new cough now, they need to immediately report that to their doctor. If they're losing weight, if they're losing appetite, especially in a smoker, because most lung cancers that we see, about 90% of them arise in smokers. If they have a new hoarseness in their voice, all right, and at times if they have new bone pains, that may be an identifying factor. If they're coughing up blood, that can be an indicator of lung cancer. They're more short of breath. Sometimes they'll present with chest pain, and that may be an indicator of lung cancer.
Now, is not chest pain also related with a heart attack or something like that?
Absolutely. So that's when we investigate them.
Okay.
And a lot of times the patient will present and say, I am having this kind of a pain. And the cardiologist will see them and say, oh, it doesn't sound like your heart. I think you need to see the lung specialist. And the cancer could be very close to the outer margin of the lung, where it's rubbing against the pleura, which is the membrane covers the lung. And that's why they have the pain.
You also mentioned earlier the weight loss, that sudden weight loss. Is there any number you have, like, how much if somebody loses a certain amount of weight in a certain period of time, what is that time frame and the weight?
Well, I think what most people see is that they see a sudden decline for no good reason.
Like in a month, 2 months?
Yeah, if they lose 5 or 7 pounds and they're not trying to lose for unexpected reasons, then they should be concerned about it, especially in a smoker. Anybody who smoked more than 20 years, a pack a day, that's usually enough.
Yeah.
The younger they start, the higher their chances. The more they've smoked, the more the problem is there.
Now, earlier you mentioned that 90% lung cancers is basically caused by smoking. What are the other 10%?
So the other 10% are different type of cancer, which is less frequently seen in smokers, but we're still seeing them in smokers. They're called as adenocarcinomas. We see them in women, in non-smokers. So there's always a category which is recognized as a non-smoker's cancer. And so there is a certain number. There are other tumors. We can give you some names like carcinoids and so on, but they're less frequent. So most cancers, the earlier studies that came out were all correlating with smokers. So the first studies that came out in the 1950s, the German physicians were looking at it as far back as 1929. And what they were seeing is all these patients that were coming in with lung cancer, out of every 100 cases, 97 had smoked. And that's why the direct correlation started coming up.
So have you seen lately any increase or decline in lung cancer in the United States?
Well, what we are seeing is that the lung cancer continues to be the biggest killer in the cancer world.
Sure.
The numbers are, enormous. 1 million deaths in the world with lung cancer. 158,000 are expected to die in 2015 of lung cancer, which is greater than the combined deaths of breast cancer, colon cancer, and pancreatic cancer, which make up number 2, 3, and 4. So the highest mortality and highest morbidity. In addition, we feel that the survival rate is so low with lung cancer that prevention plays the biggest role. We only have 17.8%, 18% survival at 5 years after lung cancer diagnosis. And unfortunately, there are new modalities of screening coming up, but we still don't have a good modality like we have for colon cancer. We tell everybody after 50, get your doctor to do a sigmoidoscopy or a colonoscopy. But for lung cancer, we're looking at CT scans, we're looking at biomarkers, blood markers, to see if we can predict who will have lung cancer, even in smokers. But we still don't have a complete...
So now, as we have seen in the US, at least, those of us who, read the newspapers and then articles and all, find that there has been a very serious effort both with the government and various organizations
Yes.
to reduce smoking.
Yes.
So the smoking has gone down in the US.
Yes.
And it is directly reflected in less lung cancer patients.
Right, absolutely. Because what we've seen is that the number of lung cancers are going down from the 1980s and 1990s. And that is a big change. And people feel that if we can actually stop smoking in the United States, the Medicare expenses would be down by 50%. Because half of the expense of Medicare is smoking-related diseases, not only lung cancer.
How is the smoking scene worldwide? Do you have any data or any idea?
So, we have a decline in
the United States.
In the United States, but worldwide, smoking continues to be a big problem.
Okay. Is it increasing worldwide, like in Europe or Asia or Latin America?
So, I was looking at data yesterday just to see, because I do not know the worldwide figures, but yesterday I was looking up, and it seems like the data is concerning the most for Russia and Eastern Europe. And there's a dramatic increase in smoking in the Eastern European countries. India is still lower down, but I think there is underreporting.
Yeah, I think that could be the, yes.
And in South Asia, the other problem is that there's also a lot of smokeless tobacco. People don't smoke cigarettes. They'll eat pan masala.
Right.
They'll eat, pan with tobacco in it.
Sure.
And so...
And also they smoke so many other things, like bidi
exactly.
and hookah and all this stuff.
Right. So the figures are a little underreported. Because I saw one figure saying that India had at one point in time the highest tobacco consumption in the world, but cigarette smoking was not the top problem. But I think that's the problem, because they also deal with tobacco related illnesses, but for cancer they're dealing sometimes more with oral cancers. If they don't smoke, if they chew the tobacco, they get other problems.
What about electric cigarettes?
Yes.
How that works? And is there any study on that and cancer?
So, we talk about the stopping of cigarette,
right?
Prevention of smoking.
Smoking.
Or teaching our children, that if you have to pick up an addiction, this is the worst addiction.
Sure.
Remember, nicotine is very similar, if not worse, than some of the hard drugs. All right. There was a study done in which what they did was people who smoked, they did their brain scans 10 years later. And said, okay, we're going to do your brain scan, but we're going to give you a little nicotine. And what they saw was that there was increased lighting up of the brain as soon as the person was exposed to nicotine 10 years later. So that is the amount of addiction that you get with nicotine. And so to get people off nicotine, there are different modalities which are being tried. Unfortunately, there's not too much data on e-cigarettes. And what I'm worried about is that e-cigarettes are going to become a replacement for regular cigarettes. Kids in school, they're going to see the e-cigarettes, and they're going to see that they're going to think it's going to be less harmful. But that's not the case. Still you're going to get high amounts of nicotine. So I think it's a good modality in the sense that if you're not able to get on any other modality of treatment, that you can try the e-cigarettes to get off the regular cigarettes. So use it as a de-addiction way. But But what I'm worried about is that the way it's being sold in the markets and tobacco companies are getting involved, it will become a primary mode to get more nicotine into you.
So now, cigarette, as you said, that being
Yes.
the number one cause of all these things, and as a physician, I'm sure that you are dealing every day with such patients who are smoking. What is your advice to them, how they should stop smoking?
So, cigarette smoking, what I tell them is, I give them a approach which is multi-pronged. So the first thing I tell them is, I explain to them what is the smoking going to do to your lungs. All right.
So what it does? Tell
Okay.
us.
So let me tell you. So, the lungs are composed of the bronchial tubes which supply the oxygen to the lungs, and then is I call them the airbags or small sacs in the lung, which are the alveoli, which supply the oxygen into your blood vessels. So the tube passes the oxygen, and the sacs transfer the oxygen into the blood vessel. And now what you're doing with the cigarettes is that not only you're causing inflammation in the tube, you're causing irreversible damage to the air sacs. So it's like this fishnet, which is catching the oxygen molecule, is going to be permanently damaged. And it's irreplaceable. There's no way that it can be regenerated. So now what happens is there's less oxygen going into your blood vessels. So gradually, the first thing that happens in smokers is they have a cough, there is inflammation of the bronchial tube, and then you hear about chronic bronchitis. Then you talk about emphysema, where now these air sacs are damaged. So there's less and less oxygen flowing into your blood. All right. So we try everything from our end, medicines and everything. But remember, now you're causing this irreversible damage to the sac, and eventually you're going to be end up on oxygen. That's the only way to increase the oxygen levels. And you're looking at chronic disability with COPD, which is another name for chronic bronchitis and emphysema, a broader term, chronic obstructive pulmonary disease.
Now, what is the impact of second-hand smoking?
So, let me just go back a little bit to the cigarette smoking, since we talked a little bit,
Sure.
and I think it's it's a very important subject,
Sure.
for everybody. So, how do I approach it? So, the first thing I tell my patients is, listen, you have to decide on a quit date. All right, you come to see me, that means you made up your mind. All right, or you have a problem today.
Sure.
All right, so either you're developing COPD, I will identify you. All right. So number one, we need to get a quit date, because I can give you all the medications, but you have an open faucet on the other side. I keep pouring water with medicines, and
Sure.
it's going to go out.
Sure.
So you decide the quit date. All right. So once you come up the quit date, then the second thing is we've got to find what is the right thing for you. All right. So tell me, where do you smoke the most? So people say, okay, I drive 24 miles every day. Takes me an hour to get to the city. So I'm smoking 2 packs, 1 pack going in, 1 pack coming out. All right. So I tell them, okay, so this is the first thing we're going to do, is you're going to stop where you smoke the most, whether it's your house or your car. You got to stop that. All right. So just identify yourself that this is one thing I'm not going to do from tomorrow. All right. Even cutting back for the first few days is good. Number 3, you're going to have nicotine addiction. All right. So what we have to do is we have to get you de-addicted. You are going to have symptoms. You're going to have craving. You're going to be irritable. You're going to be upset with your spouse. You're going to feel angry at times. You're not going to be sleeping well. And these are symptoms of nicotine addiction. The symptoms are going to be maximum in 3 days, and they're going to persist for 3 months. All right. You're not going to sleep well at night. So I have to take care of that. And that's where the physician's expertise come in. So we have medications, we have nicotine patches, even the e-cigarettes you talked a little bit about, which I'm not a great fan of because of, but if that's what it takes, that's what it takes. So we usually come up with a regimen for them. And they're good drugs. I can name a few. One is called bupropion, all right. The other one is a market name called Chantix.
Mm.
And one of the drugs, the bupropion, works well with the nicotine patch. So we usually use it in combination.
So if I have a cancer, I'm diagnosed with cancer,
Right.
and I stop smoking.
Right.
So does that have any impact on healing?
Absolutely. So what happens is once we treat cancer, lung cancer, the chances of a second cancer happening are also very high.
Okay.
All right. So once you've treated the primary cancer, you're still at risk of getting another cancer, a recurrence of your cancer, and you're exposing your lungs to the same, toxins, as we call them, carbon monoxide, the ammonia gas, the tar. And so if you avoid that, that's going to prevent you from getting a problem. And I tell my patients, if you're 30 and you quit smoking now, you're going to have the same years to live as a healthy person who's never smoked. And if you're 60, you're probably going to have a few years less, but you're still going to have a reasonable quality of life and lifespan. So even at 60, if you can quit, you can still make a difference.
So the quitting at any age is better.
Absolutely,
Okay.
absolutely.
So now let us talk also about the second-hand smoking.
Yes. So the second-hand smoking, what happens is that the lung cancer risk. Let's talk about that in this context. So what we've seen is that the risk of lung cancer, if you smoke, is 26 times of a non-smoker.
Okay.
All right. So if you are a smoker, you increase your risk 26 multiplied.
Which is huge.
Right. And if you are a second-hand smoker, you are a quarter more
Okay.
than a non-smoker.
Okay.
All right. But over the period of time, it depends how close you are to the person. Is it your spouse? Is it a co-worker? Are you on the same room all the time? And that will increase the risk of your getting either COPD or, as I said, a quarter more of getting lung cancer. But again, it's a combined.
So in the patients which you see with lung cancer issues and problems,
Yes.
do you have any, can you give us some sort of a demographic idea? What percentage are women, what are men, what are, if we have other ethnicities?
So, it's a male predominant thing, but women are as likely to get lung cancer. The smoking seems to be the greatest risk.
Are there many?
On the numbers, on the American population, blacks seem to have the highest incidence. The white Americans a little bit less. The Asian Americans are lower. The American Indians, the native Indians seem to have a moderately high risk, more than the Asian Americans, more than Asian Americans, but not as high as the African Americans.
Okay.
Yeah.
Do you have any data or numbers about the Asian or Indian population and
Yes.
smoking and lung cancer?
Yes, so I looked up some studies yesterday when I was preparing for the talk, and there's a study which is interesting from 2011 from New Jersey. So they studied, they did an epidemiological study in New Jersey, and what they did was they looked at the South Asian population, and
In the U.S.?
in the U.S. In New Jersey, and see how many people were smoking, and they found that the Indians seem to have a higher incidence among the three groups, Bangladeshi, Pakistani, and Indians, of using the smokeless tobacco.
Okay.
So they were doing more of the pan masala, which had tobacco in it, or the pans. And the Pakistani and the Bangladeshis had a higher incidence of cigarette smoking. The problem was that they were not utilizing the services for smoking cessation at all. So there's a great underutilization. The white American population was going to the physicians more frequently, identifying the problems, calling it's called as the 1-800-QUIT now. It's a line, and that's shown to be very, very helpful. If you do the medications, you do the counseling with them, the incidence of, your chances of quitting smoking are extremely high. And they were underutilizing all these services. And the incidence of cigarette smoking was about 25%, 24.3% in the Pakistani population, for example. And they were unable to quit. The incidence remained same across many years.
What about any number about, say, how the smoking and the cancer situation, lung cancer in
I
India?
did not. So the I don't know if I have the figures for India, uh, but
But what is your general knowledge about that situation?
right. I think the problem what we're seeing in the developing countries, which we're going to face, is not only is there as people are moving up the ladder, you know, in the U.S. it used to be a mark of being fashionable carrying a, and I think what we're seeing in the developing countries, especially China and India, is the same thing.
Yeah, it is very
Right.
yes, sure.
In addition, on top of that, I think the biggest contributor to lung cancer and lung diseases related to smoke exposure is going to be due to the environment change.
That
There's
was
a-
going to be my next question.
Right.
Sure.
So there is a high amount of pollutant in the air in the bigger cities, in India and China.
So the pollution and environment is also a
Absolutely.
big factor into it.
Absolutely. So, when they did studies, diesel fumes were the big thing. If you were exposed continuously to diesel fumes, you had a higher incidence of getting lung cancer.
Just like smoking a cigarette, right?
Right.
Or maybe
exactly.
worse than that.
Right. So if you're sitting in traffic in New Delhi for 2 hours, getting exposed to a big truck in front of you, you probably had a few cigarettes, when you came home.
What is the worst age of getting addicted to smoking?
Smoking is such a problem. I see people tell me they started smoking at 11, 12. Um, I think I'm worried that it's the school age, college age, early age when people want to experiment, and it's becoming earlier and earlier. Kids pick up smoking in middle school, and once they pick it up, I tell people that this is a drug which is not only causing addiction, but it is causing severe organ damage. Even the hardcore drugs we see do not cause direct organ damage. There are very few drugs which will cause cancer, and nicotine is one of them.
Sure. Now, of course, we people, common people hear
Yes.
all the time about lung cancer. What are the other major diseases which affect lungs?
So we deal with, COPD is the chronic obstructive pulmonary disease, which is the commonest disease that we deal with in cigarette smokers. Younger population, non-smokers, we deal with asthma. Lung cancer, you said. We get a
Is there any connection between lung cancer and asthma? No.
No, the asthmatic population, it's a pure asthmatic population, is a little different. Most lung cancer, as I said, is in smokers, a small number in non-smokers. The other diseases that we deal with in our practice includes tuberculosis in the Asian
Sure.
population. We also deal with some other diseases like pulmonary fibrosis, sarcoidosis, and so on. But most of the main stuff seems to be.
So now, let's spend a little bit of time
Yes.
on the tuberculosis.
Yes.
I think that's a very, used to be very epidemic
Right.
in India,
Right.
and it's a very contagious disease too.
Yes.
How the tuberculosis situation is in the United States, and how it compares with India or people from India?
Okay, so this question comes up to me at times, and in the United States, the Department of Public Health runs the TB programs. So what we tend to do is, they run a very tight program, which is to identify all healthcare workers, and they do annual skin testing for tuberculosis. They also do blood testing at times for, if you've had an exposure to tuberculosis. Tuberculosis is a little different from your regular infections because what happens in tuberculosis, I call it a reactivation disease, which means that if you got exposed to the tuberculosis germ today, the germ may sit in your body for 1, 2, 3 years. All right, it's not like the flu. You got exposed today, and you get the flu tomorrow. In tuberculosis, maybe 80% of the tuberculosis is reactivation. So the germ sits in the scar tissue in your lung, and at a time when your body is not able to fight the germ, it will wake up and cause the active infection. When you start feeling poorly, you're coughing up blood, you're losing weight, you're losing appetite. So actually similar symptoms to lung cancer at times.
So this again leads to another question: is that, of course, we are very familiar and scared of
Yes.
lung cancer.
Right.
But I remember, 30, 40 years ago,
Right.
even hearing about tuberculosis used to
Right.
be as scary as,
Right.
as
Right.
cancer.
Right.
So how do you compare these two in terms of intensity, in terms of mortality, in terms of risks?
So tuberculosis in the United States, in the developed countries, uh, we deal with a very small number of resistant type of tuberculosis, but most of the normal run-of-the-mill tuberculosis is responsive to antibiotics.
So it can be, it is
So
very
yeah,
much
so
curable
we,
these
right.
days, right?
The only thing we have to be careful about, it's a fast-spreading disease. So if we identify an infectious case, somebody who's traveled widely or come back from a long travel, stayed in India, for example, for a while, and comes in with a new cough, coughing up of blood, appetite loss, and we are thinking of tuberculosis, you have to closely monitor them, maybe even isolate them for period of time so that they don't expose people. And as soon as you identify them, start them on the medication so you can prevent the spread to other people.
So what are some of the state or government guidelines if you say you diagnose somebody with tuberculosis?
So what we tend to do is we have the Department of Public Health which gets involved. So if the case is identified, the tuberculosis physician is notified of the local area. The nurses get notification from the department. So there's a tuberculosis nurse who's designated to this, who will do a case control identification, which means she will find out if how many people you were in close touch with, how many family members, where did you pick up your groceries, did you play cards, did you go to the bar, how many people did you expose approximately. And she will try to get in touch with all these people and try to screen them for an exposure. And so they will run x-rays, they will do the skin testing and identify how many people you've contracted, who have contracted the disease from this case person.
What are some of the, if you can also talk a little bit about
Sure.
the characteristics of, the lung function, the lung strength,
Okay.
how it should be and how important it is.
So, see the lung capacity, we determine depending on, what you present with. I mean, we won't run anybody, PFTs, we call it, the pulmonary function test. But if you come to me and say, okay, I'm short of breath, I'm not feeling well, I get short of breath easily climbing a flight of stairs. For a young person like you, I want to screen him. So I'll do the breathing test, all right? So the breathing test, depending on multiple factors, if you had asthma at a young age, if you're an asthmatic now, if you have any evidence of smoking-related lung damage, and so on and so forth, we should be able to give you a number. And it'll give you, as we talked about, not only the bronchial tube function, but as I call it, the fishnet.
Sure.
The alveolar function, how fast the oxygen flows from your, and depending on that, we can, provide you with treatments. If you have asthma, if you have COPD, how to improve your lung capacity so you can do more. For the smoking population, for the COPDers, I always tell them, I said, the most important thing you can identify is, or do, is to exercise. Because the lung capacity is not only an indicator of your lung, but also your upper body strength. So if you can make your upper body strength, if you can make it a little stronger, pick up, a little extra weight, go to the gym, work on the upper body, actually we start seeing improvement in the lung capacity. So a lot of times we'll send our COPDers to a rehabilitation clinic, pulmonary rehabilitation clinic, where they will work extensively, and we will see improvement, 10, 15, 20% improvement in their lung functions just by exercising.
Now, 5 tips
Okay,
you want to give to our viewers.
all right.
That these are the 5 things you must do to keep a healthy lung and a healthy body. What those 5 tips will be.
Okay, so the first thing I would say is, make sure if you're a smoker, or if you're living with a smoker, or if you have anybody smoking in the house, you definitely need to work with them, all right? Help them quit smoking. Number 2, exercise regularly, all right?
How much exercise is necessary on a daily basis?
I tell people, if you can, if you have a busy schedule, all right, if you can do about between 20 and 25 minutes moderate exercise. run on the treadmill, 20 minutes, a little bit of upper body strengthening every day. That's pretty good.
And that's have to be every day, 20 minutes
Every day, if you can. If you can't, if you can do it every other day, 30 minutes.
Any exercise is better than
Right,
no.
than being sedentary, all right? Right lifestyle, all right? Make sure you're not overweight, all right? Especially for the South Asian population, we see that we already are at high risk of diabetes, our
Sure.
incidence is very high, or double the risk that we have for the, general local population. Hypertension is high in our population. And on top of that, if you do not live the right lifestyle,
Sure.
if you're smoking or if you're not eating the right kind of food, eating a lot of sweets.
So what is your definition of right lifestyle?
Moderate exercise, at least, as I said, 20-25 minutes of exercise every day, which involves some upper body strengthening. Make sure you're not increasing your risk for heart disease, COPD by smoking. Eating a lot of fruits and vegetables, all right? And I personally feel that if you keep a good social environment, that helps. A lot of people who are smoking, get addicted to alcohol or are not in a good social circle.
Sure.
You got to find the right people, all right? If you're in constant touch with smokers, you have a higher tendency of getting back to cigarettes. Or maybe you got to, break up with some of your friends who are continuously smoking, because if you go back to the same circle, you're probably going to do the same.
Naresh, thank you very much for coming.
Thank you for having me.